Good evening, everyone. Hi. Hi. I'm Priya Ratnam, the Library Director. On behalf of the Shrewsbury Public Library Foundation Board, I'd like to welcome all of you to another talk in our series of lectures on AI. In the past year, we've hosted Professor Fabrizio Morai from WPI, who gave an informative talk on the history of AI. Legislators, Senator Michael Moore and Representative Jim McGovern, who discussed proposed regulations around AI. Dr. Yvonne Masakovsky, who discussed global security in the process of implementing AI. Today, I'm very excited to welcome Dr. David McManus, who's the founding director of the UMass program in digital medicine. So, Dr. McManus, can AI save American healthcare? Yeah. We're very eager to see what you have to say on this topic. And we are looking for good news in the field of health and science.
So thanks for the warm welcome. Can I just check, can you hear me okay in the back? Because I was going to go without the mic if you can. Is that all right? Okay, great. Well, first of all, thank you for inviting me to speak with you all. And I just will say that that's a fantastic lineup of speakers that you've had so far talking about different applications of artificial intelligence. And while AI is part of, as we'll talk about what digital health means exactly, what's the definition, we'll go a little bit, we'll draw a circle a little bit around artificial intelligence because it's one of the tools that I would say are in the toolkit of digital health. And the question, which is intentionally provocative, is can technology save the American healthcare system? And if you've got to get home for a TV show on Netflix or something that you want to watch, the short version, the spoiler is no technology by itself can save American healthcare. And really, this hopefully will be a nice conversation with you about some of the applications of technology, but also some of the need for patients to get involved in through advocacy and different avenues alongside researchers and clinicians at getting engaged to really reinvent what is, I think, a broken healthcare system. So I would like to just kick off with a few thoughts and ground rules. First of all, does anybody know who this? Well, I have it in the quote, right? I gave you a clue, and then I have his name up there. But this is one of my favorite authors as a kid, Isaac Asimov, who was a really amazing futurist, as well as science fiction author, and he came up with all kinds of crazy ideas in the 1950s, like autonomous robots that would have their own intelligence, and so he proposed that it's only afterward that a new idea seems reasonable. To begin with, it usually seems quite unreasonable. And I think we're going to be talking about some concepts that just a few years ago people would have thought would have been crazy. Questions are welcome. I did try to leave time at the end for us to have a conversation, but you, of course, can raise your hand, and I'm happy to pause during the course of the presentation. I will just put a few disclosures, as is customary for these types of talks. I have some grants from the federal government, or at least did, and as well as grants from industry. I'll try to be clear if there's any potential or perceived conflict of interest. I don't think these are particularly relevant to today's talk. So I set 3 ambitious goals for our time together. The first is to talk a little bit about where American healthcare is. Does it need saving in the first place? The second goal would be to talk about exactly what digital health means, and it means different things to different groups of people. I think that's okay, but understanding that, do a deep dive on artificial intelligence and its different applications in healthcare, and then specifically talk about my experiences within UMass, between the medical school and hospital system, at trying to actually take technology and put it into the healthcare system to try to drive better quality, better outcomes, lower cost, and more accessible patient care. So that's our goal, and hopefully we'll have a little bit of fun in the process. So Okay, this is a character named Dr. Cox. Does anyone remember this show? It was one of my favorite shows. I'm biased, of course, because I like healthcare stuff, but does anybody know what the show is? Okay, so we have our television person who I don't, can you speak? Are you allowed to speak with that?
It's from Scrubs.
It's from Scrubs, which, despite being a completely farcical comedy, is, I think, one of the best depictions of at least the way I grew up as a resident and medical student in healthcare. It's a really accurate description of an intern who's starting out just right out of medical school, and this is the crusty emergency department doctor named Dr. Cox, and he was speaking to the intern saying, "Look, newbie, the only way to judge your growth as a doctor, hell, as a human being, is by making sure you don't repeat the same mistakes over and over." And this was a really, a moment when the intern was feeling really down. He'd made a mistake with a patient, was feeling really bad. And this kind of crusty doctor came out of his shell to coach him. And I would argue that unlike this intern who did get better and did learn from his mistakes in the story, we keep repeating a lot of the same mistakes in our healthcare system. And I think we're not learning from those and adapting. And we are at a tipping point. So I want to show you a little bit of data that would support that. So first chapter is scaring the hell out of you. And the next two chapters are talking a little bit about what we're going to do about it, okay? But we got to do a little drama here, right? Okay. So I don't know if you can make out every line here, but what I'll just highlight is on the x-axis are years between 1980 and 2021. This trend has, if anything, accelerated. But the top line shows U.S. spending on healthcare. And what that's showing is that we really have outstripped spending, both in absolute terms and in the rate of spending, as opposed to most of these are, Canada, Germany, European countries, what are considered more of the heavy utilizers of healthcare, both in terms of the population, in terms of its demographics and the number of older people, but also what would be considered developed nations that really have robust healthcare systems. And we're spending a lot of money, is the point of this, and we are an outlier. This, you probably heard, has been attributed to aging of the U.S. population. So as we get older, we tend to use more healthcare services, which cost money. But that despite aging in other countries too, there's this quote unquote silver tsunami of baby boomers, but that's not just a U.S. phenomenon. And despite the fact that this is really, in Japan and in Europe and a lot of other parts of the world, there's been an increased proportion of the population in these countries that's older, but yet they're not spending as much as we are. This has huge implications. You can see it playing out in the economic sector with impacts on businesses who in our healthcare system do shoulder some of the cost of paying for health insurance for their employees. And it really puts the U.S. at a disadvantage, I think, globally. And this is having, I think, a huge anchoring effect or dragging down effect on business growth in the United States. And more importantly, it has human consequences, right? So you've probably seen increased out-of-pocket cost for services, whether it be for an MRI or for a copay for an office visit. It's had implications on access for critical services, preventive care, and I think that's as I'll show you in a subsequent slide, I think that's having an impact on our health as a country. So I don't mean to only ground this in economic terms, but I do think it's important in the aggregate to basically start by saying we're paying a lot for healthcare. And what are we paying for? So I thought this figure was really interesting. So on the right, you in essence see a bar of the U.S. spending per head. We spend about $10,000 per person on healthcare, or at least did in 2018. That's gone up since then, but this kind of gives you, the breakdowns are pretty similar. Of that money, the darker blue is on inpatient care. The lighter blues are on drugs. The 1,400 would be on prescription drugs. The next blue is on administrative costs, other things like preventive and sort of other. So my point in breaking this down is it looks like it's about half on the things that you would think would be healthcare costs, like the doctors and nurses and places where you get your care. And the rest is really on what I would consider to be administrative and back office type stuff that I don't think really drives value much in healthcare. No offense if anyone's a medical biller in the audience, but the point is that we've created this fragmented system, back and forth, paperwork moving, lots of people, lots of cost. And I think that my point of this graphic is to simply show you that if you were to simply address that issue, we would be down to what Europe pays for per head for a lot of its healthcare. And that's shown in the subsequent graph below of the comparable country average, where you have, yes, doctors and nursing costs are certainly higher, but if you really look, it's the reduction in other things like prescription drug costs and administrative costs. Okay, and on the left are some, just sort of like I guess these would be called sort of fun facts that you can impress your house guests with. We pay 10 times more than Holland does for the same CAT scan. Same exact technology. You go in, you pay 10 times what they do in Holland. In Switzerland, where they're a very expensive healthcare system, we also pay 3 times more for a drug used to treat rheumatoid arthritis. So, we're getting the same product for a lot more out-of-pocket costs. So we're paying more, so we should be getting more, right? The truth is we're not. And this is a complicated graph that on the x-axis has a lot of the same data, which is showing left is spending less, right is spending more. And here you see on the y-axis plotted how long people are expected to live. Now, this doesn't capture all elements of healthcare, certainly, and not all of it is direct. Like, for example, I happen to think, although it's not listed as the biggest threat to children, but gun violence in the United States, for example, and gun-related deaths are something that we see high rates of in the U.S. I don't know that that's necessarily a byproduct of the hospital system per se. It is an American problem. But in the aggregate, I do think you can take some observations that we're paying a lot, but there's a disconnect with a benefit in terms of our longevity. Okay, I recognize that living longer is not always living better, but there are other metrics of child health, quality of life that relate to recovery from certain conditions that track with this data. So we're paying a lot disproportionately, both out of pocket and as a country, and we're not reaping benefits that I think we should. So very interestingly, hopefully this shows up here. Here we go. Okay. This is from a survey of patients in the United States. It's a few years old. I think I got this from a survey that maybe it was post-COVID, so we'll say like 2 or 3 years old. And what's plotted here are 30 country average in the blue, and the purple is the U.S., and the proportion of people when asked, thinking generally, what do you see as the biggest problems facing healthcare in your country? So these are Americans responding to this question, and they have all these different options. And so first of all, what's interesting is our access, while it's a major issue, is still a lot better than a lot of the countries that we hold as less expensive, ideal, if you will, state-run healthcare systems. But look at the places where the purple is outstripping the whatever color that is, teal, I don't know. But the point is that cost of access and bureaucracy appears to be a major difference for American respondents to a collection of 30 other countries in the aggregate. So this kind of comes back to the fact that I think Americans are perceiving that the system is getting really complicated. There's a lot of layers of bureaucracy. It's costly to get in. But I do think it's important to sort of look at how we're performing relative to other countries. And we're not perhaps as bad as we thought. I happen to know that Canadians, for example, commonly drive from at least Quebec down to this area to get healthcare because they're waiting on back surgeries and other things that are queued for 9 months or longer. So there are pros of our healthcare system as well as cons. I don't mean to be doomsday here. So one of the things that you might think is, okay, spending a lot. Someone's got to be benefiting from this. So the hospitals, they must be raking it in. We're spending all this money. And I took these headlines from 2022, between 2020 and 2023. And so Mass General Brigham, I have Tufts Medical Center here, Boston Medical Center, and UMass Memorial itself. And I think in the aggregate, healthcare systems are not actually doing well. Now they're increasing in their revenue, but their costs are going up significantly. And there was a really great piece written in the, I think this is from actually the Times Magazine. No, yeah, Times Magazine, by a physician and I think it was an economist was a co-author, and they wrote a great perspective piece that stated their hypothesis that coming out of COVID, about half of all nurses retired or resigned. And subsequent to that, a lot of the hospital systems really scrambled to stay open. And this was also true of physicians. But actually, I would say that the bigger change since 2020 has been in the cost of nursing technicians, people who are cleaning the hospital system, the service sort of elements of healthcare that you have to have as sort of your costs. I will just say that that's increased probably 4 times in the last 4 years within UMass. So while, sure, healthcare costs are sort of, healthcare revenues might be, see more patients, maybe you could, but the costs of doing business have really changed during the same period, such that all of these hospital systems are losing money doing things the same way they were before. And I don't think that it's a better experience. So you probably, if you haven't, this is great, but if you've been in an emergency department in the last few years, it's really, really a difficult scenario. You're often in the hallway, there's a lot of waiting, you're in the waiting room. And really what I want to try to emphasize here is with growth of the population, collapse of the Steward healthcare system in our region, with collapse of other for-profit enterprises in healthcare for these very reasons, there's a strain on hospitals and clinics, and part of that is because labor costs are up, revenues are flat, and so I would say doing business the same way is just not something that can continue. I think we have to really change how we deliver healthcare in order to stay open. We don't have that luxury of sort of a very profitable system that can just continue. And then the other element that I want to highlight, again, this is one of the main characters of Scrubs, Turk, with his somewhat boneheaded orthopedic doctor friend here in the scrub room. And, you know, what ultimately Turk decided was to follow in the footsteps of a lot of smart people like me who went into medicine and not surgery. I'm biased, but I think the point here is to say there's a survey of medical professionals that's shown at the bottom. And those that were left behind, those that stayed in the hospital systems, the physicians and nurses and all the people who are frontline staff, the emergency medical folks, the paramedics, the EMTs, the folks who do respiratory care, when surveyed, they said basically they're under super amounts of stress. They're running around trying to do the jobs of 2 people. They feel burnout. Some of the quotes at the bottom say an almost insurmountable workload that has caused the remaining individuals to become completely burnt out. And 41% of healthcare workers were asked, when asked whether or not the national shortage had affected them, said it was having a major impact on them. So almost 3/4 said that there was some impact. So I think if you were to survey folks in this region, it would be higher. So the point of this is not just that we have an overburdened healthcare system, we have the people who are working in it saying it's broken for them. And so this is going to drive even more people out of doing health. So I think not just for patients, but for the people who practice medicine, there's a need to change. Okay, I want to just pause for a second. I understand it's a pretty gloomy picture, but there's a lot of reason for hope. But I want to go through a couple of definitions first about what this digital health thing is from the perspective of a few different groups. And I'll tell you, I'm sort of biased, but I'll tell you some of the things I think. So just pivoting to what is digital health. So the FDA defines it as a set of tools. Tools like mobile health, so things like your Apple Watch that can measure your the presence or absence of certain rhythm problems. It can define it as a piece of technology that is a telehealth software that might run on your computer and enable a visit with a healthcare professional, or other pieces of technology, things that you could buy at Best Buy or get in a store. Other groups define digital health as a discipline, meaning that it includes programs, things like hospital at home, which we started at UMass a few years back. And what does that mean, hospital at home? Well, that means you have to retrain, doctors and nurses to practice differently. It's a different, job. And that's sort of what this definition is getting at. There's a group called HIMSS, which is Health Informatics Society, that really gets beyond the people and the tools to the concept that it actually means connecting and empowering people and populations to manage health and care environments. And then I really like this definition from a thought leader in the field who really talks about digital health being a cultural transformation, inclusive of both changes to how healthcare providers do their job, but also how patients access and consume healthcare, with the ideal that it changes the way patients can engage. It, quite frankly, it empowers them, and gives a new sort of a whole new way of engaging between healthcare providers and patients and democratizing care. I like this thinking because a lot of times when people give talks about AI or digital technologies, they really focus on the whiz-bang gadget. And interestingly, it's really not about the gadgets. It's about how we use the technology. I mean, we put a man on the moon with a computer that right now is inferior to the one in your like calculator, right? So I'm pretty sure that we're not limited by our technology or our computing capabilities. We're really limited by I think our imagination, I think our toughness, are willing to make some sacrifices and hard decisions. There will be winners and losers in this transformation. I think, for example, knowledge-based workers like physicians, some of the diagnostic domains that we have, I think can be done by a piece of software. And it's giving up some things and really focusing on others, because I think there are other elements of doctoring that are quite rewarding that a computer can never do. So, but I think that's an important point about really thinking about digital health in a different way from just a tool to being a change to healthcare. Because I would argue there's no such thing anymore as digital health and healthcare. It's just healthcare at this point. So for the other thing, does anyone know the story of Garry Kasparov versus the computer Big Blue? I see some people nodding. So this is intended to, so over a series of really cool, great story of training of this computer to compete against a grandmaster at chess, which is, of course, a game with defined sets of rules. It's the perfect type of training set for a computer. And really, the question, how do you make a grandmaster blink, is intended to prompt me to say the ideal application of artificial intelligence is for certain types of activities, particularly when there's a defined set of information and constraints can be put on it. And you can really, like, for example, a radiology image where there's certain data that comes in, a computer can be trained on a series of prior games or prior images, and then it can spit out an interpretation. Computers really struggle with more complex problems. They struggle when data is murky, and they struggle when interaction is required and emotion needs to be incorporated, and personal and cultural elements need to be incorporated into the ideal decision. So, artificial intelligence is a theory and also a way of developing computer systems that are able to perform some of these tasks that normally a human brain would have been required to do. Things like speech recognition that we use on our phones, or decision making, as might be a co-pilot for a person doing your colonoscopy to see whether or not the image shows a potential cancer, and saying, oh, a pilot, in this case gastroenterologist, maybe you want to look over there. I think I picked up on something. The same way similar systems are actually used for real pilots these days to reduce human error from fatigue and other factors. Machine learning is use and development of systems. So that part is similar to AI, but it's a subset where the computer is able to learn and adapt without a training and retraining and by a human being. So hopefully these definitions are, everybody's an AI expert now. I say that, right? Everybody's heard of AI. But in fact, in the audience are people that I know that actually have programmed in AI and know more about this than I do. So including Priya, who's 15 years old, right? How old? What 15? Yes, I'm right? Okay, so you got an expert over there. So did I get this right? Okay. I got it right. Okay, good. So if you think about it, I put this picture up of a healthcare provider who's frustrated. How many of you have had the experience when you go to see your healthcare provider in the office and they're looking at a computer and they're typing and they're not looking at you? Who has had that experience in the audience? Okay, me too. And so an ideal use would be to, for example, and this is a use case that we're using at UMass in some of the offices. There's maybe a recording of the interaction, the same way we can dictate to Siri, that can just take the natural history that you're getting. You could even speak to the exam that you're conducting. That goes into the computer and it generates the required documentation instead of having to be, at a keyboard typing and looking at a screen. The other thing that really an ideal use of artificial intelligence in the context of a clinic visit and use of the computer is to prompt the person. So I don't know that people understand, but before you come in, ideally your healthcare provider is doing some homework. The same way, kids have to do homework. And they're supposed to be reading what happened to you, look at your labs, maybe make a phone call to another healthcare provider to get some information so that they can come in the room prepared and knowing what to focus on. Well, I think that's another place where, ChatGPT is very good, for example, of summarizing everything that's out there and on the web about a particular topic. If we could apply this, and we are, in the context of what's in your record, it'd be great if it flagged, hey, did you see that so-and-so was in the emergency department and they broke their toe and their labs were off, and other elements that really can sift through the reams of data that exists about you in the record. I would add that another place where AI can help is to clean that record, because a lot of the stuff that's in your chart is absolute junk. And it's actually risky because it gets put in there, it doesn't get taken out, and a lot of that actually puts you at risk. And I think that's another place we can reduce medical errors. Okay, so I love this slide, but it's another super scary one. So I spent a lot of time on this, okay? So the idea, I gave this to my boss, by the way. Just, I took this from a presentation I gave my boss, and I said, this is you. You're here on this burning platform. It's time to, change and think about things. And then, of course, everyone knows, or I don't know, you guys, did you go to Blockbuster? I went to Blockbuster all the time. And then, Netflix came along and had this new model, and it was going to be great, and it still is great. But then even Netflix changed, right? First it was the discs, and then now it's the things, the boxes, like a vending machine, and now it's just streaming, right? So there's this classic business sort of change, consuming another type of business that this is supposed to convey. And I put a picture of a community hospital here on the left. That's Blockbuster. And I'm worried that this is an actual Newsweek. I didn't modify that with AI. That's an actual Newsweek cover showing Jeff Bezos. I think it's pre-buff Jeff Bezos, I would add, in a white coat. And it's posing the question, do you trust Jeff Bezos with your life? This was shortly before Amazon, which you guys probably all use, I do, had the button in the top left that you could press for medical care. Right? You can, I don't know. How many of you actually have used that? Can I just get a sense? Okay. Maybe not the right crowd to ask that to. But there are a lot of these online direct-to-consumer services that would previously you'd go to, a local clinic to get. And so is this what we're dealing with here? Pretty interesting, because think of it this way. The Amazon model, right? They're not having to keep an emergency department open at night, right? They also can choose who they work with. If you're not a Prime member, they don't have to deliver you healthcare. So it's a completely different model, and quite frankly, it pulls off a lot of the younger people, and a lot of the folks who could, quite frankly, and are subsidizing older folks who may need their help in terms of subsidizing healthcare systems. So it really, it's an interesting question and a scary one to think about. Okay, so just a couple of things. Video visits on the left, proportion of people owning a smart device like a Fitbit, people using it to track health metrics like a blood pressure cuff, people who are filling out information about their healthcare provider online, and people who are using online health information. This is from 2022. I think this, particularly with some of the new AI, generative AI features in ChatGPT and others, this has even gone up from here. And you could see real growth across these areas in the last over the last 5 to I guess this would be 5 to 10 years. The other way that you can look at this is in the context of AI. Huge numbers of new companies are being established. You see how much the stock market is linked to. I don't know, is anyone buy Nvidia stock? So AI related market is just exploding, and healthcare is no different. People are creating new companies. They are scaling up existing companies, particularly in and around mobile health, healthcare analytics, and digital health systems. I don't see a lot of new hospitals opening. Now, how is AI being integrated into healthcare? I just picked a few examples across a few domains. This is not intended to be exhaustive. I quite frankly ran out of space on the screen, so we could probably go on, but these are probably some of the most common ones. In the medical imaging space, so we're using at UMass an AI that pre-reads the image and puts at the top of the file those that the AI thinks are risky, where the patient may have something like a bleeding problem or a clot or something that really the radiologist on call needs to pay attention to. So prioritization or triaging, that's an existing application right now of an FDA-cleared AI software product. There are a number of companies actually using AI to develop new drugs, to reduce the time it takes to find new drugs. Many of you may be aware that with use of antibiotics, that there are these resistant bacteria that have developed, and you need to screen a lot of compounds. And in the old days, like 5 years ago, you would have to go through and actually test a lot of these in a very lengthy and expensive process. So certain companies are taking all of the compounds and libraries and screening them with AI to try to identify potential hits and reduce the time and cost that it takes to identify new drugs for certain conditions, cancer, as well as infectious diseases and other things. I think one of the places where it's really exciting to think about AI's application is actually pulling data from a few different sources, including your genetic data. So a lot of folks have used 23andMe before it went belly up. But I think there's a push for folks to analyze genetic data to, in essence, provide you with predictions about where you're vulnerable so you can get ahead of potential cancer, cardiovascular risk, and other domains. The other place that I'll just highlight is predicting disease, or identifying disease. So Google, for example, has a piece of software that runs on your smartphone that take a picture of your eye, and instead of having to go to an ophthalmologist, it can analyze your retina for the presence of potential retinopathy. Other examples, I mentioned the application of AI to synthesize information in the electronic health record. That's an already existing set of apps that we are using now at UMass, limited, but we are starting to use them. And then, of course, for monitoring, we've got all these devices but we're not necessarily pulling those pieces of data together meaningfully. And I think there's some really interesting AI software that are pulling those together to basically give you a deeper understanding of your health. The other place that, quite frankly, I see a real opportunity, and I mentioned the workforce shortage, there's a real problem in terms of access to care for people who have depression or anxiety, to things like behavioral and mental health services. And there are some really interesting new companies that make this one creatively named Wobot, which is a chatbot that instead of talking to you about your bank account, can offer cognitive behavioral therapy. And actually, you might say it's crazy, but this stuff has been shown to work. And it really is based on training from recordings of CBT from therapists. And so that's a clear place where, when you say like, well, is it better than a person? Well, maybe not, but there's not a person in a lot of cases to do it. So to me, that's a perfect application. But this is actually, although it's at the bottom, and I apologize, to me, this is the best application. Applying AI to all the stuff that I showed you that costs you a lot of money and I don't think offers you a tremendous amount of value, which is in the context of actually administering your healthcare. And I think whether it be in the context of preparing paperwork to go back and forth to insurance companies, getting authorizations, that should entirely be automated, I think, and taken out of the purview of people to have to do that. Okay, so I want to talk to you a little bit about the digital transformation of healthcare at UMass, tell you about a few of the projects that we have going, and then I really do want to leave time for a discussion. So again, this is the intern I told you about before. You could probably guess that. You can see the disgust on the face of the older doctor, Dr. Cox. And he's here saying, I'm going to write you a couple of prescriptions. This first one is for a mallet so you can pound some sense into yourself. And I think hopefully we're trying to pound a little bit of sense into healthcare at UMass through these endeavors. So I want to talk to you about 4 projects. I will say these are some pictures I'm super proud of people who, for example, stood up the remdesivir van for treating COVID, some photos from the DCU Center where myself and others worked when COVID was hitting us. These are some students trying to, drop immunizations for people. So, like, to me, this was one of, I think, my proudest moments of being a healthcare provider was to really try to be there for our community when we were needed. And one of my fears is if we outsource too much of this to Jeff Bezos, he ain't coming to the DCU Center. So, so the point is, how do we reinvent ourselves to compete really for your care? Because you're the consumer. You get to drive the boat here, and we really need to provide good access, the convenience of Jeff Bezos, while also being there for some folks who are really sick and maybe vulnerable. So anyway, let's talk about a few of these. So this is the first one that's an example, and you say, like, this looks really boring. What this is a screenshot of an app that we developed at UMass that was trained with a team from MIT that came and worked with us. And we built a predictive algorithm to actually look at who's getting better and who's getting worse. That's it. We basically tried to train a model on millions of patients who were in the hospital, and we worked with the hospital medicine doctors and teams to develop a model to try to take a stab at, and you can start to see over here, probability of discharge in the next day. And, so-and-so who was in this bed had a 95% probability according to this algorithm. So you say, well, why do you need that? Hospitalists are really smart people. They know this stuff. True, but some of the people who might be needed to prep your readiness for discharge might not have all of this information. And so I think that's really, so this is a picture of a team. I don't know, I got everybody's permission. You can see the lady in the red pants is super engaged, by the way. but this is the typical rounds that's happening in a typical medical unit at UMass. There's the doctor and resident, like you saw in the picture. This would be Dr. Cox, I guess, and that would be Jesse. But there's also a whole team of people, therapists and social workers and case managers, that are trying to plan, like, okay, where's Mr. Jones going? Like, do we need to get rehabilitation? Do we need to call their family? What are we doing? And so really where this application I think can be advanced and ultimately be helpful is to just automate, communicate, and try to get ahead so that we're able to, for example, put up, as we are in the North Pavilion, your estimated time that you're going to go home. I think that's pretty cool. That's next to every patient now on their room. You can see on a digital board when we think you're going to be ready. And I think that's empowering to a patient to just have that. Because the doctor may know it, but I mean, you saw him for like 5 minutes at 7 a.m. You were asleep. You had to go to the bathroom. You don't remember anything that they said. And when your family member comes, you don't remember. And now when they come in the room, you can see. These are little things that I think are actually really big things. The other thing that I want to say is just a little bit about training. I put up pictures of really smart looking young people on here, but because I love this quote, there's a lot of, I think, resistance among healthcare providers worried about loss of their jobs. And as there are in every field. But I like to say that AI is not replacing physicians, but it sure as hell is going to replace physicians that don't use it. And I think that that's really the message here, is that we're training doctors and researchers at UMass right now in developing these technologies and really being experts in them. So what's next? What are we thinking about? We're thinking about developing and implementing AI models to try to do better triaging, better prediction of when you need to potentially go into a higher level of care, like an ICU. We're trying to warn folks when they're at risk, prioritize patients for expensive procedures, to say like, okay, so and so could wait, so and so cannot. To better utilize what is, I think, our most precious resource, which are the people who are working nights and weekends to take really good care of you when you need them. And a lot of the applications also came out, or innovations came out of COVID. And I do want to specifically talk about hospital at home, because it uses a lot of these technologies. So in 2021, COVID was still here. We were trying to figure out how to take care of patients. We had this experience of trying to put up a field hospital, and then the government actually, I think, did something really smart. And I said it, okay? I said something nice. They waived a prior requirement to pay a hospital for your care only if you were in a licensed hospital. And so all of a sudden, something we knew to be really effective, hospital at home, was possible because you could get paid for it. And so we started doing it. We started creating, this is from a Boston Globe article, because we were one of the first in the country to really scale this up. And we were moving patients from out of the emergency department, where they were at risk of infection, of lack of sleep, into a home environment. And this was all enabled by a combination of some of the sensors and technologies that would be called digital health, plus changes to how we did work. It meant that we had to go into the home twice a day with nurses. We had to visit with patients as physicians over a computer, and a completely different skill set had to be developed, both on the parts of the doctors and nurses, but also the patients. They decided when they would be seen, not the doctor doing rounds. And so just how we worked with patients was totally different. So this was really a great story, and we just had our, I think, 3,000th patient admitted. And I know some of the members of the audience, because some of you actually have been admitted to this hospital at home. So I think that's pretty cool that we were able to build this. And none of this would have been possible just a few years ago without technology, digital health, and AI. The other thing that we're doing increasingly is related, which is the concept of community paramedicine. So we're starting to, so the prior example of hospital at home is for pretty sick people who come to the emergency department. But this service is the idea of, we would go to your home if you're not quite sick enough to need to go to the hospital, and that the paramedic, who's got some pretty good training, but with the assistance of some new technologies, like maybe an ultrasound probe. Now they make them, they're just about the size of a pen. But instead of a cardiologist or an expensive, highly trained technician doing it, it's a paramedic, and they're really guided on how to use the probe. They can perform testing. they can get a lot of information, then they coordinate a consult over the smartphone or a tablet. And this is called mobile integrated health. For example, we've got a project with our geriatrics clinic where the geriatrician can call up and say, Mrs. Jones, I don't like their labs. I think you need to go and give fluids and maybe check them for pneumonia and try to treat them so they don't get sick enough to need to be in the hospital. And this is also something that we're really excited about, and UMass is seen as a national leader in. The other place is on the other side of health, which is in the preventive health space. We're trying to mine information in the electronic health record about you to try to identify risk. I mentioned AI applications might predict who's going to get diabetes, who might have a heart attack. And we're trying to use that in coordination with primary care doctors to actually coordinate virtual visits by nurses with patients we feel would benefit from a visit, and then actually getting them treated for their problems. And I think this is super cool because if you think of this is like data and kind of really maybe boring, but I got to show you a picture. This is not boring. So this is an actual photo of a Zoom. And this is a Zoom, and I put little labels of the different people. Madonna Azar, Dr. Azar, is a great diabetologist. I don't know if she's going for a walk or what she's doing, but she's got her iPhone. I mean, imagine this. This would never happen in the old medicine. You've got a bunch of doctors meeting, and the program manager is running the list of patients, and they're all talking about patients identified by this algorithm. So I've got maybe 100 people to talk about, and they're going through saying, what do you think about Mrs. Jones? You've got the nephrologist saying, I don't think the kidneys are that good. Cardiologist over there who's got, I don't know what she's scribbled on the wall, but she's talking about what she was worried about for the heart. And I just think this is, like, think about it. I talked about people and technology. This is honestly a little bit old school in that there used to be like doctors' lounges in hospitals where, I don't know, doctors would talk to one another. That's gone from healthcare because everyone's running around like they're chicken with their head cut off. But this is almost like empowering people to get back to what is, I think, when you think about, like, as a patient, I feel safer thinking that there's a group of people that actually are all looking at me and talking about me because, Matt Niemi's really smart, but he might have missed something. But Van might pick up on what Matt missed, and they're talking about different perspectives, bringing all of their expertise to bear. And that's all empowered by the ability to prioritize, like, okay, these 100 people we've identified, we need to talk about them this week. And this has continued actually to today in the Advanced Therapeutics program. Okay, so these are some really cool examples of applications, real world, going on right now. But one of the things I want to say and acknowledge, and I love this graphic because it imposes humility. So x-axis time, y-axis change. I think we've got technology at this exponential rate of change, right? I mean, look at education. Like my daughter's in high school. How she learns and uses ChatGPT legally to learn, totally different than how I learned, right? So that technologic change, so social is starting to sort of, she and her friends are saying, okay, how are you using this technology? Healthcare could be considered a business. It's kind of changing, but like what I showed you isn't like that impressive. It's compared to ChatGPT, I mean, like what I'm doing is peanuts. And then there's the policy piece, which you've heard about. Due respect to Jim McGovern, who I think is one of the smartest people around, but Congress and the Senate can barely tie their shoes, right? So they're lagging behind all of this stuff. And I think in terms of safety, when you think about healthcare applications, like we have to prioritize safety above all, right? But we have very few regulations that I think make sense in this space, and that's lagging. I just want to acknowledge that and say, while the technology, it looks amazing, I think we have to be very careful about the applications because the pace of technology change has outstripped what we, I think, understand. So there, to this, I like this quote, and I highlighted a few things. We don't really know where there's going to be, for example, an impact on jobs. And I think as we deal with certain union groups, as you talk to certain, I mentioned the billing office and where I thought that might be a good application, but some people work in the billing office, like, right? So we got to consider the pros and cons of some of these applications and figuring out benefits I mean, a few years ago, I think all the kids going to college were told to be coders. How'd that work out now, right? Because many of them are losing their jobs. I don't know if you've seen in Microsoft and a few other companies that employ a lot. So I think, no, that's not to say coders can't be successful in an AI world, of course, but it changes things. And I think it's going to change things in healthcare. And I do think we have to be careful to not lose the good. And there is a lot of good in healthcare. So one thing I will say though, and fits with my business lagging. So this is a graph. I love this. So this is the share of U.S. job postings. So if you looked on the internet for a job in 2018, this would be, and this is the same as it is today. This comes from Brookings study. They did a look at across industry. So of course, information technology, technical companies. At the time, they had a higher hit rate for saying we want AI skills. Okay. Then there's like retail, and then I think there's like travel. Then there's, I think, like, what's a good example here? Recreation, real estate, healthcare. So we have not been recruiting people who want to have competencies. We really don't have the skill set. We're not taught it in medical school or nursing school. We really don't have the right technical skills. And it's an extremely difficult thing to bring people with those skills into healthcare because, first of all, it's medieval compared to the companies they're working with. It's in person. It pays less. The benefits stink. I just told you that everybody's stressed out. So bringing people in from these highly competitive fields to help us out and figure out how to use AI is super difficult. And I mentioned some of the other challenges here, but I just thought this was amazing that we're behind like transportation and warehousing. So. I do, so one of the things that I think this is an interesting survey that shows that a lot of folks are now using telemedicine for their minor illness care and for prescription refills. I don't think this is surprising anymore. Now, this is an advertisement for the Amazon primary care service saying you don't have to wait in the waiting room. I'm always on time. I always. Just kidding. I'm not, as many of you know. But they say we start on time. You can get your care anytime you want. I mean, a lot of checks on the left, and I'm a lot of X's. So the truth is, this is what's being advertised, and this is really because there's not the constraints that are placed on Amazon. The other thing that I would say is, do you trust your data to be in the hands of Jeff on his yacht with the lady, that they just got married and they're gallivanting around? What's her name? What's the
Lauren Sanchez.
I knew someone, Lauren Sanchez. So I don't know if Lauren has access to your data, but Jeff probably does have access to your data. But maybe Lauren has access to your data. But the point is, like, this is a little bit concerning. And so one of the other things that we're trying to be cognizant of is to assure that those AI algorithms that we're using have been trained properly, that they're deployed properly. And I will say I'm really proud, not just within the school, but within the hospital, there's really good AI governance where the tools, people can really sell almost anything these days. And they come to you saying, I've got the greatest AI and it's going to tell you who's sick. And you got like, slow down, buddy. Let's just test it before we apply it on real people. So I think I showed you this what's next slide, but let me wrap up with the following sort of thoughts here. And I think, and this is where I hope we get into a conversation. I think trust is really important. It's probably the most important thing. And I think part of why you're all here is because you're really interested in how healthcare systems in your area are going to change. And I think you ideally remember that you have relationships with your doctors and nurses. I think you want good care, but you want us to be successful. And I think we need to be successful for you. We also, I think, you take an oath when you become a healthcare provider. to do no harm, to be careful and to try to help the people that are entrusting you to care for them. And I don't know that that trust is the same with technology barons or other folks. But the truth is, trust can be lost. I think, what is it? My dad used to say, trust is built up in drops and lost in buckets. So if you have a big data breach in your hospital, if you apply AI and it hurts somebody, like that really hurts trust in your patients. You have to be careful, but you also have to understand that patients at the end of the day sometimes can't wait. And we have to find ways of providing access better than we are now if we're going to compete against a single click on Amazon, because they sure as hell have figured out how to get me a package in 24 hours. And I haven't figured out how to get you healthcare that fast. So, there are some things that we need to learn and change to do. So, in the end, I don't think that a piece of technology will save healthcare. It does need saving, and I do think it needs disruption. Unfortunately, I think if we're not careful, AI is as likely to damage healthcare as heal it. I will say the next 10 years of healthcare change are going to be at a pace unlike anything you've ever seen. I think between retirements of many primary care doctors and nurses I just mentioned, the workforce just isn't going to be there. So we have to get used to interacting with chatbots potentially for some basic stuff. Like I was thinking the other day, I'm embarrassed. I missed my primary care doctor visit. He was really mad, but I felt like sheepishly I was like, "Can I get my labs? Can I still get my labs done?" And I had to send the message in. Of course, he's like waiting the day, looking at the email, responding yes, putting an order in. Like, why couldn't that have been done by an algorithm, right? I mean, why did he need to do that? He needed to do that. So that's the type of place where I think we should really try to focus on innovation. So I would like to charge you all to get engaged and get as knowledgeable as you can from each other. Keep talking and really, I think, keep voting to try to make sure that your vision for what you want from healthcare is yours. I think you're entitled to it. I believe that it's something that we as a society should be judged by in terms of how we take care of sick people. And I hope that you'll help drive this change as opposed to a technology gazillionaire who may be in the business for some good, but may have some other goals as well. So with that, I'll just wrap up and say if it's okay, we can maybe talk a little bit. Does that sound fair?
Yeah.
Great. Thank you.
That's great.
Yep.
First of all, in many ways, Dr. McManus, you've established trust tonight because all of us are experiencing you as someone who is thoughtful and making this change in a way that everybody can be informed and participate in. So I think a round of applause just for that, because we're all feeling that, right? I know he'd like to take a few questions, and so if you want to raise your hands, because I'm guessing there's going to be a lot of people who want to ask questions, and we'll do the questions for 10 minutes, okay?
Sure.
And at that point, we'll stop. I'm going to just recognize people's hands. The first, yeah, go ahead, that's good.
Hi. Hi, my name is Raghu. The question I have is, you very elegantly presented, the cost, healthcare cost per person, or is it per year, was $10,000?
Yeah, it's a couple years old, so it's gone up a bit from there, but yes.
Okay,
Yep.
so most of it was administrative costs
Yep.
and stuff. And in your later slide, you showed that administrative costs and triage could be helped by technology.
Yep.
So how long will it take for us, the customers and patients,
man.
to see that trickle
Yeah.
down cost effect?
Yeah.
And let's spend money?
Yeah, that's a great question. So, I mean, we have this, people overuse fragmented, but so administrative costs, those costs I would put into a couple of buckets. There's the hospital side and provider side bucket, and then there's which are separate by law in the US, right? Those are two separate things. Like doctors cannot work directly for a hospital. That's supposed to be kept separate to protect you, because we're not supposed to just, use a drug because someone told us to. right? But those are two separate buckets, and insurance. But then there's the insurance bucket, right? So they employ people, they carry costs, and they pass some of that cost on to you. They also, I don't know if you've noticed, do you know what one of the biggest companies in the United States is? It's United Healthcare. Yeah, and so they are a for-profit business. So they have shareholders, and so they try to make a little bit more than they cost, and then pass that back as a profit, right? So, yeah, I guess it's shocking to me. What for-profit business says, you know what we want to do? We want to make less money. Because, think about it, right? We want to drive overall costs down, but we have an industry where all the incentives are to drive them up. So I think, we can reduce hospital side administrative costs, I think, and physician costs. I describe those a lot, but I think we have to get to a place where we have to start asking some real questions about, like, do we want the biggest company in the United States to be one that, owns all of the pharmacies, many doctors' offices, the insurance plans, the pharmacy benefit managers, and every piece of healthcare? Like, do you want a non-governmental agency to be doing that? I would say that's a wee bit dangerous. And I think it will delay the benefit being applied. Although they may lower costs, but I don't know that they'll lower costs to you, if that makes sense. Because I think they'd lower costs to keep profitable. Does that make sense? Yeah.
Thank you. For
Hey,
an
Shyam.
excellent- Hey,
Yeah,
great.
how you
Thank for a
doing?
Very excellent.
A great oncology doctor. Yeah, if you ever need one. Hopefully you don't.
Thanks. Thanks for a great talk. I had a question about preventive oncology and the role for AI in that field. Do you think that AI could be potentially used to analyze prior CBC or complete blood count values for patients to predict the likelihood of eventually developing a hematologic cancer?
Yeah, so you all get regular, I shouldn't say you all, because that's making assumptions. But I mentioned before when I went to see my primary, I do think getting regular blood work, looking at your cholesterol and a few other basic things is a really good thing to do, depending on your background in medical history. Part of that is something called a complete blood count, where you get a check on are you anemic and other features. And so what the good doctor was asking is, like, it's one thing to just look at a single point in time, but what if a computer could look back over 10 years worth of these lab tests that you've had done, all of which were quote unquote normal, but might not have been normal for you, or might have been changing, and be useful at predicting who's going to go on to develop a cancer? And the answer is, I think, absolutely. That's a perfect type of data to train AI. And that's like a chess game, right? I think that's a perfect chess game, because you have discrete data, right? You have a clear outcome, who got cancer, who didn't. And I think you could really teach a computer to look at it. The only constraint is that not everybody gets the blood tests. But for those that do, yeah, I think that's a great application of AI. Questions?
It was a great talk, thank you.
Thanks.
You brought up a case study where you've used AI for predicting discharge times.
Yeah.
Where are we with, or where is UMass with incorporating AI for other cost-saving opportunities, like preventing rehospitalization, or maybe even due to medication non-adherence? And I think UMass is a treasure trove of data, where there's demographics and every other piece of information that you've collected over the years.
Yeah, we're really in our infancy about applying algorithms to use cases like readmission. You mentioned medication adherence. We really are just starting to try out software to do that. I will say that there are a couple of places where it's been used to identify people who need specific types of rehab, but quite limited. I think that's probably, I'll come back in a year and we'll talk, because I think in the next year or so, that's going to be where we go next. You're very smart to say, because readmissions are bad for patients. They're really very difficult. In many cases, they're preventable. Like if you go to someone's house, they don't have their walker that you wanted them to have, or their medicines got messed up, and various other things that you could prevent. And so I think, to your point, that's a great application of a predictive tool to say, okay, we can't send a person out to everybody's house, But these are the people that we maybe want to check in on. Like to me, that would be a great application.
I'll look forward to your talk next.
Yeah, that's okay. That's good.
There's one right here.
Thank you. What do you think the applications for holistic medicine of treating mind, body, and spirit would be for AI?
Oh man, that's a good one. Okay, so a couple of, I know this isn't really answering your question, but a few things immediately come to mind, like virtual, oh gosh, what is it called? Is it Kabat-Zinn? What am I thinking of? Yeah, but mindfulness. So offering, for example, mindfulness over telemedicine is, I think, it's not really what you're talking about, but still people doing it. But at least, it makes it more accessible. I'm aware of some folks doing mindfulness for pain management. There's some apps that I've started to see be used for that as well. I absolutely think, in the same way that in cognitive behavioral therapy, some apps are being developed. I absolutely, first of all, I believe that that these are evidence-based treatments. The concept of holistic medicine, has not always been embraced as effective. It is, I think, particularly for dealing with some chronic, challenging problems. And I think, like a bot, I think could instruct you on certain, exercises, right? Could potentially provide some guidance that would, if it were trained properly, could generate even a voice and talk you through certain things. So I think that would be I'm aware of several companies looking at these different elements of what I would call holistic medicine. I think it'd be harder to do acupuncture that way, but I think a lot of others. It's a really good question, and I think it plugs into the fact that there's this behavioral health space is really, I think, a huge need that we're just not meeting. So I think you can completely avoid the idea that you're eating someone else's lunch. You just take care of people with anxiety, depression, chronic pain, because I don't think they're getting much care. That would be where I would apply it.
One more question. Right here, Priya, right in front of you. Priya, right here.
So, on one of the prior slides, we had a few grants that you're receiving from
Yeah.
pharma companies and stuff like that. Is it mainly for drug discovery, and does AI help in that area, or it is too premature to say that AI can augment drug discovery?
Yeah, I don't know as much about the space of AI in the context of pharmaceutical. That might be a very interesting talk for a speaker from inside the industry. My grants were collaborative grants to do research, largely on applications for smartwatches and whether or not they could be used to detect and treat patients differently. But they certainly, they're investing heavily, pharma is, in AI to try to streamline the process, because it's typically, I think it's something like 10 years from just drug sort of projects beginning to actually coming to market. So I think even if they shortened it by a year or two, that would save them a lot of money, reduce the cost of the medication, I think, for you. And so there's ample reason to be optimistic, but I actually am not aware of a drug, for example, yet that has been found by AI. I'll do some digging, but I think we should probably invite an expert to really talk about that. That's
great.
Yeah.
Well, that's probably a good spot to
Yeah,
end.
okay.
We can't thank you enough for coming tonight, Doctor, and you. I just want to say quickly, the foundation is responsible for making this presentation possible. We do have the Distinguished Speaker Series. We do have Geraldine Brooks. Those of you that are avid readers would recognize that name. She's a New York Times bestseller. She's going to be here September 29th at the Oak Street Middle School at 7 o'clock. Should be a very interesting presentation. In addition to that, the foundation supports staff development, supports expansion and continuation of technology, and is also responsible for some capital, current and future needs. And so we're always looking for financial support. So anybody who wants to follow up today's presentation and make a gift to the foundation would be happy to take it. And we look forward to seeing you at our next presentation in September. Again, one last time, thank you very much, Dr.